the coexisting diseases. My topic is cataract surgery in pterygium. I am Dr. Sunil. I am consultant director of Sanjeevani Eye Hospital at Patna. The presence of a pterygium interferes with the keratometry measurements related to calculate IOL. Pterygia flatten the cornea and induce astigmatism. The impact of a pterygium on the curvature of the cornea increases the longer it is. This results in inaccurate keratometry reading and some residual prescriptions left over after cataract surgery. The modalities of management are two. One is sequential cataract surgery, meaning thereby कि first pterygium and then cataract of a certain space of time, and there is a simultaneous and pterygium and cataract surgery. Simultaneous pterygium and cataract surgery is necessary only in patients who cannot easily access eye care facilities. A small asymptomatic pterygium that doesn't bother the patient could be left alone and may not affect refractory outcomes after the cataract surgery. Typically, lesions smaller than 3 mm don't tend to create irregularities of the cornea, but closely look at the corneal curvature before making this decision. If it seems to be affecting the corneal curvature, they should be then they should be removed for a good, stable, regular corneal curvature for cataract surgery. Patients with small pterygium at the limbus with regular Myers on keratometry, regular corneal curvatures in topography, and a low or absent astigmatism can have cataract surgery before pterygium excision. Pterygium excision should not be done. Cataract surgery can go on. What led to this? There was a review of literature by Sharma B. Bajoria and et al., and which was said refractive outcomes of simultaneous pterygium and cataract surgery with fibrin glue. Then it showed that the steepening of the cornea after combined surgery results in myopia. Therefore, the IOL power should be selected appropriately. In the second literature also, like predictability of intraocular lens power calculation after simultaneous pterygium excision and cataract surgery, the conclusion was that simultaneous pterygium and cataract surgery was safe and effective, and the accuracy was moderately predictable. However, it should be noted that a significant myopic shift occurred post-operatively, possibly resulting from the steepening of the cornea after pterygium removal, especially when the size of pterygium was large. So sequentially, hence the need for sequential surgery. Some that look very thick or red might have an increased chance of causing more astigmatism than thin ones. But, however, if you look at the topography gives you the clear picture, and it doesn't show a large amount of astigmatism in topography, and it's not bothering the patient, it can be left. Should not be touched. This is large fleshy pterygium, and that's the regular astigmatism on pentacam. So the sequential surgery. Ensure adequate healing. Measurement after pterygium surgery after 4 and 6 weeks or 6 and 8 weeks after pterygium. Keratometry or topography should be repeated 6 weeks after pterygium excision and preferably repeated 2 weeks later to determine whether the astigmatism is still changing or not. When astigmatism is not changing, then only you can go ahead with the cataract surgery. Now the choice of IOL depends primarily on the presence or absence of corneal astigmatism. In patients with significant corneal astigmatism or demonstrable higher order aberrations, which is HOAs, any IOL of one's preference can be used. Keratometry or topography should be repeated 6 weeks and 2 weeks later to determine whether the astigmatism is still changing. Phototherapy keratectomy can benefit patients with superficial corneal opacities, and PRK can help to regularize an irregular cornea. If the pterygium surgery leaves an irregular cornea, irregular astigmatism, these procedures can be had before the cataract surgery. Now the choice of IOL depends primarily on the presence of corneal astigmatism. Toric IOL. Patient who had large scarred pterygia may be left with significant irregular astigmatism. Irregular astigmatism, toric IOLs are not of much use, but contact lens may help. Toric IOLs can be used for regular corneal astigmatism of more than 1 or 1.5 diopters. Multifocal IOL are not a good option in patients with irregular astigmatism and higher level of HOAs or any patient with higher degrees of corneal aberration. Now the surgical tips. Any surgery that involves extensive dissection of conjunctiva, like ECCIOL or SICS, should be best avoided in this patient because pterygium surgery always does with that conjunctiva, so scarring is more. So incision should be, meaning thereby that a phaco should be done with a small incision, very small. So, it is advisable to use a clear corneal cataract incision. Clear corneal, why? Because limbal stem cell deficiency has been implicated as a major cause of pterygium, and pterygium surgery may lead to further loss of stem cells if limbal incision is giving. So a clear corneal cataract incision, and that also phaco. So review of literature, the conclusion is that post-operative refraction errors were positively correlated with the length of pterygium in the combined group. The unpredictability of these errors recommends sequential surgery in cases with concurrent pterygium and cataract. So pterygium excision tips in simultaneous surgery. Again, that article was that Sharma S.K. Bajoria, refractive outcomes of simultaneous pterygium and cataract surgery with fibrin glue. Conjunctival graft adhesion with fibrin glue is an ideal alternative to suturing in these combined cases because it shortens the operative time, it is easy to use, and is associated with less post-operative inflammation and discomfort. So for a conclusion, in all other cases, sequential surgery may be preferred. Pterygium surgery should be sequenced before cataract surgery when the pterygium is large enough to induce corneal curvature changes. This order will significantly reduce the incidence of refractive surprises after cataract surgery, which I have already said in the review of literature, that it leads to myopic shift. So it leads to myopic shift, so IOL power calculation might give spring surprises. So small pterygium near the limbus, especially those that are atrophic, can be left alone and one can proceed with cataract surgery only. However, topography may detect subclinical extension of the pterygium into the center of the cornea. So that ends. Thanks, Rajesh and Anita. Any questions? Thanks.
I think, what do you practice in your clinical practice? I mean, do you do the pterygium surgery first, or do you do the cataract surgery and then do the pterygium surgery later? Or you do it simultaneously?
First, now the advancement of pterygium surgery has come with that fibrin glue and the conjunctiva. First, what pterygium surgery we used to do was, in simplified form, it can be called a nochectomy. In the nochectomy era, so that was done with that, both the things that used to be done, but now we realized that simultaneous it should not be done. So now I have improvised myself that before I was doing together, now we don't do it. However, if the patient is from the rural background and we feel that that patient is not going to come after pterygium surgery, that patient might not come for the cataract, and it's patient with a rural background, little amount of this what myopic shift would not matter, and we'll go for the both. That's your wisdom and your judiciousness.
I think the house agrees with this, that usually what we do is that, very rightly said, if the patient really doesn't come for follow-up, then only you take this decision. Otherwise, doing a pterygium, and then what extent of corneal de-roofing, de-surfacing you have done along with the pterygium, you have to use post-op medications if you do a concomitant cataract surgery. So you never think of doing a cataract surgery in combination with the pterygium. Even if the pterygium is there and it is hindering the cataract surgery, it will be better than when you've removed the pterygium and proceeding ahead with the cataract surgery. So either you do the cataract surgery first, if the pterygium is not that big enough, or you do the cataract surgery, pterygium surgery earlier if it is large enough encroaching into the cornea. So this is what we are mostly following.
Most of the time, if the patient, most of the time, if the pterygium is atrophic, it's not, we don't go for the topography and all. Normally, if it's if not interfering, we can go only for the cataract surgery.
See, in these cases, we rely upon the biometry findings of the other eye. We never follow or rely on the biometry of the affected eye, because it's bound to be erroneous.
Now the more practical question is, you don't do a pterygium before a cataract surgery.
isn't it? You do a cataract surgery in whatever circumstances, if it is feasible, you will do a cataract surgery before pterygium surgery, right?
No. If it is sequential, pterygium surgery should be ideally done before. After 6 weeks, it is again reviewed, and then again after 8 weeks, if the astigmatism is not changing, then we go for the cataract surgery. But practically,
That's the ideal
practically
one.
what I said was that with the patients come with a rural background, they cannot come to you quite often. So what you do is, if pterygium is significant, if pterygium is not significant, we will take the IOL power of the next eye if it is pseudophagus, and then we'll do that same thing, cataract surgery only. But if pterygium is significant, we can do both the thing at one sitting in exceptional circumstances. Ideally, it should not be done.
Then if you do the same sitting, then how good going to, because you are aberrated the epithelium.
Exactly,
then you-
administration
why
of
you
the
are putting
steroid.
steroid?
Yeah,
See,
yeah.
what,
Chances
yes,
technically
yeah.
Yeah.
So,
Yes,
nee,
so
this,
better to
these are the
Better
situations.
to avoid. But in that rural background, 85-year-old person comes. You go for the Ayushman person comes, and he is not going to come next time if you feel. That is in exceptional cases. Otherwise, normally you should do a sequential one.
Usually in these cases, what we try to practice is that this is a kind of a case where you have a mature senile cataract along with a progressive
And
pterygium.
rural background patient, aged
Progressive
patient.
pterygium with a mature cataract. Now, the patient requires something. It's not a rural background even, sir. The patient requires something to be done. It's a hyper mature cataract along with a pterygium. You need to do. So, what you address is you want to do the cataract. And secondly, you are thinking that whether we should do it in the same go pterygium or not. Now, what the question what Dr. Nagendra is trying to point out is that definitely putting post-operative steroids is an issue.
Yeah.
For the first week, we follow it up. We try to put on a systemic regimen for 3-4 days and give non-steroidals and lubricants in that cataract surgery where the surface has been deprived, and after a week then you switch over to
It
the
should be avoided. It should be avoided.
steroids. That is the best way because you have really debrided the cornea. And at that point of time, those background patients, even well-off, I'm not talking of those background patients, even well-off patients may land up with any kind of an infection, and that is really not desirable.
And pterygium has improved. The surgery with a graft and the fibrin glue, it has improved a lot. First pterygium, what we used to do, again I repeat it, that was the typical term was nochectomy.
Yeah.
You just catch it, you just nocho it, and that's all. You just
But
cauterize it.
even if you do the pterygium and you do a graft, that corneal portion is completely denuded.
True.
So for that, post-op regimen has to be for the first week. When you're doing it concomitant, you have
Very
to
tricky,
change
very
it.
tricky.
So
Yeah.
these becomes a little
Then-
tricky.
Very tricky.
Apart from all these things, if you do have suffered in one patient, right, the surgery was done, I thought let me give him a bonus pterygium surgery. For 1.5 months, he was coming with watering and redness and itchiness and all kinds of very nicely done surgery, but ocular surface disorder, the most unhappy patient.
Yeah.
This is all what happens in those, yeah. So in those cases, usually unless that pterygium is completely covering the cornea,
You should be avoided.
and if the patient is having a hypermature cataract with a pterygium,
Only cataract.
I prefer to do only the cataract first, let him be there for at least 2-3 months, and thereafter you do a planned pterygium surgery very nicely.
If the
And
patient
during
comes
the-
come for
and
follow-up.
during the cataract surgery, you take all the K readings of the other eye. Because this is really unpredictable.
Thanks, Dr. Sunil. We
Thank
had
you.
very
Thank you
long
very much.
discussion on cataract with pterygium. And
These, I think, this topic, I think, was very pertinent and very practical. And I think no set guidelines, no fixed guidelines have been there. Everybody is getting experiences and sharing their experiences on the platform, and they are arriving at a consensus, I hope so. So that's why this IC and all the topics were very, very interesting.
We learn by committing mistakes. Like Anita said that
Practical, yeah.
practical कहीं guideline नहीं है. You have to formulate or share your experiences and all.
we learn by committing mistakes. Like Anita said now that simultaneous surgery was done, and after 1.5 months, watering, redness, we all learn by mistakes.
Yeah.
We used to do it nowadays. We go for the sequential one now. It's in the rare cases only. Otherwise, you can leave pterygium as such. There is no need to touch if it's a rural background, little amount of astigmatism doesn't matter, slight amount of corneal astigmatism. Why? Why go for the pterygium? Only cataract.
Correct. And later on, if the patient comes and he earns for that surgery, you will do a planned pterygium surgery. That's
Thanks, Dr.